Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Thank you for joining us for this live webinar to help prepare you and your team for upcoming changes associated with the implementation of Patient Driven Groupings Model, or PDGM as we've come to know it. As the home health industry prepares for the start of PDGM, effective use of technology will help providers ensure compliance, streamline operations, and grow revenue while improving patient outcomes. Today, we will provide you with the background and key components of PDGM, essential technology considerations for PDGM success, and how automation can help your organization thrive in a changing regulatory environment. My name is Stephanie People. I'm the Director of Brand Marketing here at Axxess. Before we get started, let me just tell you a little bit about us. We are the fastest growing home healthcare technology company, providing solutions that improve care for more than 2 million patients nationwide and are trusted by more than 7,000 organizations. Axxess offers a complete suite of easy-to-use, innovative software solutions that empower home health, home care, and hospice providers to grow their business while making lives better. Our collaborative culture, focused on innovation and excellence, is recognized nationally as a best place to work. And I can vouch we are a best place to work. So today, you will hear from Andrew Olowu, Chief Technology Officer here at Axxess. As Chief Technology Officer, Andrew is responsible for the development and execution of the software portfolio and leading the overall technology strategy of a company. Andrew was recognized as CTO of the Year for his contributions and innovative approach to IT solutions and how he has elevated the scope and influence of IT in the home health industry. Prior to joining Axxess, he held a variety of leadership roles in information technology and led digital systems development for BMW, HP, T-Mobile, Reed Smith, and other brands. So before we get started, just a couple of housekeeping items. Everyone's phones are muted. However, you may submit questions throughout the webinar. If time permits, Andrew will answer as many questions as he can at the end of the webinar. If we don't have time to answer your question, we will follow up with you once the webinar has concluded. So following the webinar, we will provide everyone with a link to the slides and a video recording of the webinar on our website, axxess.com. And with that, I turn it over to Andrew. Thank you.
Thank you, Stephanie. Good morning, good afternoon, wherever you may be. It is my pleasure to present the PDGM technology considerations to you this morning. And, I wanted to start by really sharing that our industry is really heavily regulated. In fact, it's one of the most heavily regulated healthcare sectors. And it's easy for us to get lost in all the regulations and for you to become overwhelmed by the constant changes, rules and regulations, and conditions of participation. But the need to adapt to the latest regulation can feel like an obstacle to streamlining your operation. However, if you have the right technology partner that can help you navigate the ever-changing landscape of home health, you will be successful. My presentation today will focus on the latest regulatory change, Patient Driven Groupings Model, or fondly called PDGM, from the technology perspective. So our agenda this morning really is to do a little overview of PDGM, kind of get you caught up to how it evolved to what it is today. Then I'm going to move on into the meat of my presentation and cover technology considerations for PDGM. I'm going to go as far as making recommendations on things that you can do to prepare on your side and all the things that Axxess is going to do to prepare you to be successful in the new year when PDGM goes into effect. And lastly, we'll touch on going beyond PDGM. There's a lot of exciting new opportunities in home health that PDGM really brings, and I'll cover some of that, some of the ways that Axxess is going to make you successful beyond PDGM. So let's start with CMS's intention with PDGM. Before we get into PDGM, it's important to understand how CMS sees this. What their intention really is from the material they put out is a shift from volume of care to value-based care. And you can think of it this way, that our current payment system, PPS, really allows agencies to utilize as much therapy as needed. What CMS, under the recommendation of MedPAC, is to get rid of therapy utilization and focus more on the patient's needs. So the new case mix on the PDGM really focuses on the patient's characteristics and patient's needs. And I'm going to share that in the upcoming slides. And lastly, CMS really wants to modernize Medicare. They really want to get to the point where they're keeping up with a lot of the newer technologies available out there. So this new model really is intended to address the need to eliminate therapy volume as part of the payment determinant. And it's really been a long-standing goal to move payment to be associated more with value rather than volume. So the origin of PDGM really starts with the Impact Act. The Impact Act really laid the foundation for PDGM, and it was introduced into law as the Improving Medicare Post-Acute Care Transformation Act of 2014. When it was signed into law, the intention was to create a uniform method of patient assessment. As you guys see it today, it's OASIS D. So the Impact Act really gave us the current version of the comprehensive OASIS assessment that we have today. What it also did was set a timetable for developing and implementing and reporting quality measures. So we're beginning to see a lot more quality measures be introduced even under PDGM. And lastly, it really laid the groundwork for future payment reform, and that gets us to PDGM. But the Impact Act was necessary, a precursor to the act that introduced PDGM. It was in order for us to get the accurate payment, we needed to clean up the comprehensive assessment to create a uniformity across the post-acute space. In fact, if you guys didn't know, this is a fun fact, the SNF industry is also going through a payment reform this year. Theirs is called the PDGM, and it's Patient Groupings Payment Model. And it's very similar in terms of its elements and content to PDGM that's related to home health. So the first thing that needed to happen was to create a uniform method of assessing patients in the post-acute space. And the next thing was to look at the reimbursement model and tie that closely, again, to the same patient's needs. So PDGM really came out last year in the form that we understand it today. It was introduced and signed into law by President Trump under the Bipartisan Budget Act of 2018 in February last year. So what it did was it did a few things, but the most important element of what the act did was to mandate payment reform in home health. I want to pause for a second and really flesh this out. It's important to understand that PDGM is simply a payment reform. It is important that you understand that so that as you move forward with PDGM, you understand all the elements that you need to address that impacts your revenue and your reimbursement. So PDGM is simply a payment reform. The conditions of participation remain the same. Nothing has changed there. Now, CMS was also required by this act of Congress to adjust the home health prospective payment case mix. And so when that came out, Medicare decided to evolve that into PDGM and have a totally different case mix. And I'll go in a few slides and explain the new PDGM case mix, which is different from the current PPS case mix. And also lastly, really, it's to align home health payments to patients' care needs. The components of the case mix addresses different areas of the patient's needs, and you'll see that in upcoming slides. Also, it's important to note that that Congress also wanted this to be introduced in a budget-neutral manner, where it was budget-neutral from the standpoint of the revenue, that it had no impact on the reimbursement that's paid out to you, the provider. And also, they did also factor in a behavioral adjustment. And what that simply means is they're assuming that your use of therapy would change, that most agencies will no longer use as much therapy as they use in the new model, and that they will be taking a 6.4% discount off of your payment. After you've determined your payment, it will be taken out as just the fact that they believe that home health agencies may eventually figure out a way to game the system. So that's CMS's way of saying that we still believe that people find ways to sort of manipulate the system and get paid more. So a lot of there's a lot of advocacy going on here from national associations in fighting the behavioral adjustment that was factored into the PDGM payment. And I'm sure you hear from Axxess and other sources in the future on how successful those efforts are or unsuccessful. And also, CMS really wrapped up the bipartisan act in the final rule that was released October last year. In it, the current version of PDGM as we know it was finalized. And I'll get into some components of PDGM in a second, but I also wanted to make a note that even though PDGM is finalized in last year's rules, we do anticipate that CMS always reserves the right, and we anticipate that they may introduce some changes in the proposed rules for 2019 and maybe in the final rules for this year. We anticipate that that could happen, but right now we're marching forward with the final rules released in October 2018 that defines PDGM as we know it today. So understanding PDGM. So PDGM, the Patient Driven Groupings Model, replaces the home health prospective payment system. The current system, PPS as it's called, has been in effect since the year 2000. And PPS, if you guys recall, replaced the IPS system, the interim payment system, between 1998 and the year 2000. Similar to what we see today, PPS is being phased out and it will be replaced by the new payment system, PDGM, in the year 2020, January 1st. So the effective date for PDGM is January 1st, 2020. There will be no reliance on therapy, as I mentioned earlier. This new PDGM has a totally different case mix that determines payment. And we'll get into that in a little bit. The focus of PDGM, again, is on patient need. It's no longer on the volume of therapy or the other elements that used to determine the payment. So what are the key components of PDGM? So the first thing is PDGM introduces the concept of 30-day payment periods. The 60-day episode remains. So in your plan of care is still for 60 days. Your OASIS assessments and plan of care should still be for 60 days. So the 60-day concept, the 60-day episode concept remains. So think of it this way: 60-day addresses the care and 30 days addresses the payment. So 60-day episodes remain, but now you have two 30-day payment periods within a single episode. Also, another key component of PDGM is that each one of the 432 case mix groups introduce their own LUPA thresholds. So currently under PPS, LUPA is 4 or less visits in an episode. With the concept, under PDGM guidelines, LUPA thresholds are determined by the case mix groups. And so we have a new range. Some case mix have 2 visits or less as a LUPA threshold, while some other case mix groups have 6 visits or less as their LUPA threshold. So it's important for you to understand the LUPA thresholds for each of the new case mix groups that we have under PDGM. And how is this case mix really determined? So how do we get 432 case mix categories? Well, we have 5 different components that comprise the case mix that has been adjusted under PDGM. The first component is an early or late episode timing. So those are 2 options, early or late. The other component, again, that factors into the PDGM case mix is the admission source. So where is your patient coming from? Was it an institutional discharge or community admission? And also these 2 elements affect how much reimbursement you get under the new PDGM model. So those two options also exist on the admission source. We now have an expanded clinical grouping. So we expand the clinical groupings from 6 to 12. As most of you guys know that are clinicians, the medication management, teaching, and assessment group has been expanded. So there's 7 groups under the medication management, teaching, and assessment. And also we have the neuro rehab, we have wounds, we have complex nursing interventions, we have musculoskeletal rehab, and behavioral health. So we have 12 clinical groups. So your patient can find themselves in any of these 12 groups. And this is based on the principal or primary diagnosis codes, the ICD-10 code that drives the diagnosis. We also keep the functional levels. These are OASIS-based items that give us 3 options under PDGM: low, medium, high. And questions from your OASIS assessments from the M questions 1800 all the way to M 1860, as well as 1033, M 1033 are items that are used to determine the functional levels under PDGM. So we have 3 options under the functional levels, and that is current with what we have under PPS today. The last determining factor for our new case mix under PDGM is the comorbidity adjustment. This is based on your secondary diagnosis codes. So CMS recognizes that there are some diagnosis codes that are just as impactful to the treatment of the patient as much as the primary diagnosis codes. And so there's an adjustment that's made there to compensate you more for those patients that have those types of case mix. So the 2 options under the early and late episode, the 2 options under the admission source, the 12 options under the clinical groupings, 3 options under functional levels, and 3 options under the comorbidity adjustments drive the 432 new case mix groups that we have on the PDGM. And just to recap, 30-day payment units have been introduced on the PDGM. So there's the first 30 days, there's the second 30 days. You're required to submit a wrap at the start of the first 30 days, a final at the end of the second 30 days, a wrap at the 31st day of the episode or the first day of the second 30 days, and at the end of the second 30-day period, you're allowed to submit a final claim. Again, the 60-day episode care episode remains, but PDGM introduces 2 payment periods, and we have unique LUPA thresholds for each of the case mix groups. All right, moving on. What is the impact to you from a billing standpoint? You have to consider that PDGM will have impact on the billing. I did mention that PDGM is simply a payment reform. So really most of the change to you should happen in the billing. But the truth is you have to consider that PDGM will have clinical impact, will have operational impact, will have a financial impact, may affect your cash flow if you don't thoroughly understand what PDGM is. But the billing impact is that the wrap and final billing methodology really remains the same. PDGM introduces the 2 30-day payments within an episode. So for the first 30 days, for the single episode, you're doing 2 wraps and 2 finals. But the contents of the wrap, the contents of the final, remain the same. So the methodology remains the same. For a wrap, your OASIS assessment needs to be completed, and your first billable visit needs to be completed. As far as your finals, the first 30-day final and the second 30-day finals, the same rules apply. You should have transmitted your OASIS assessment to the ASAP system. You should have compliant face-to-face documentation from the physician. You should have signed and dated all your orders. You should have a signed and dated plan of care, as well as completed all your visits in order to get paid under the for final claim. So the methodology for wrap and finals remain the same, but PDGM introduces the 30-day payment units. Additional things to consider. Wrap auto cancel rules still apply. So if you don't submit your finals in a timely manner, your wraps will auto-cancel following the same rules that exist today. The only difference is the time is a little bit compressed because now your wrap, you only have the first 30 days and the second 30 days. So the timely filing time that you have is now shorter. The duration is shorter. So your claims not received within the greater of 60 days from the end date of the episode, or 60 days after the wrap is paid, whichever is greater, will result in a cancellation of your of your wrap. So again, the auto cancel rule still applies. So you do want to submit your wraps, but you also need to submit your finals in a timely manner so your wraps do not auto cancel. The rule is still in effect. And lastly, this is important to note, newly certified agencies as of the start of this year will not receive wrap payments on the PDGM. They'll be required to submit something called a no payment wrap. So they're required to submit a wrap, but with zero payment on it. Now, there's some speculation that this is a goal of CMS to eventually get to eliminating wraps, but we're not speculating today. Agencies that started this year, will not submit a wrap that pays. Instead, they'll be submitting a wrap with no payment on it, and CMS will provide most of the reimbursement on the final claim. So those are the things to consider when you think about the impact of PDGM on your billing. From a clinical standpoint, really, the conditions of participation and the guidelines have not changed here. However, because of our compressed time frame and the 230-day payment periods within your episodes, it's critical for you to submit and complete timely and accurate documentation. So from a clinical standpoint, it's important that you look at solutions, mobile solutions that allow you to capture, your clinicians to capture documentation at the point of care. This is critical to ensure that nothing holds up submitting your wraps and finals under the PDGM payment system. Coding, care planning, and care coordination also need to be reviewed for best practices. From a coding standpoint, there are items under PDGM that will not, there are ICD-10 codes that will no longer be accepted under the PDGM clinical groups. So for principal diagnosis codes, you have to make sure from a coding standpoint that you're using a list of acceptable ICD-10 codes. In general, Medicare just doesn't they want you to be as specific as possible when it comes to the codes that you choose. So general muscle weakness will no longer be accepted under PDGM. And I'll get into some of the tools that Axxess will be introducing to ensure that you're coding up to the PDGM standards. There are tools that we can put in place today that alert you whenever we determine that a principal diagnosis code will not be groupable under PDGM or will not fall into one of the clinical groups that will yield a payment on the PDGM. We will be warning you this year and preventing you from selecting those codes next year. So care planning, care coordination, and coding needs to be reviewed to make sure that you're in compliance with the PDGM guidelines. Also, you need sound clinical strategies to manage LUPA. As you heard me say a few slides ago, that each of the new case mix that we have on the PDGM have their own LUPA thresholds and have their own LUPA limits. So you have to make sure that the number of visits that is provided throughout the course of the episodes or the first 30 days or the second 30 days is managed properly. The good news is Axxess will be introducing a few features in our software that allow you to manage your entire episodes and look at your visit utilization, your LUPA utilization, as well as a host of other items for you to consider as you move through active episodes under the PDGM, once PDGM goes into effect. And then the last thing is goes back to coding to avoid the questionable encounters, QEs, or unspecified symptom codes. So your coding becomes very important, and we're glad that Axxess will have tools in our system that allow you to be compliant with the new PDGM guidelines. So what determines what would make you successful on the PDGM? Really, we feel like there's three buckets that you need to look at to be successful on the PDGM. The first one is you really have to look at your people, make sure you have a great culture in your office, and make sure that you're driving success within your organization. The next thing is you really need to look at your processes, and I'll get into more details for each one of these items. And lastly, your partners, so your technology partner, looking to make sure that they can enumerate the changes of PDGM and they understand the key components of PDGM and are actually introducing features and functionality that will make you successful on the PDGM. So the 3 Ps are really the keys to success on the PDGM. So let's talk about your people. What are things that you can do? The first thing is your people have to understand the regulatory changes. They need to be able to understand what PDGM is and what it affects. PDGM is a payment reform, but because of the payment structure of the 30-day unit, it's imperative that your operation from intake to billing is sound and that you're following best practices. But it takes an understanding of the regulatory change to be able to determine how you implement change within your organization and prepare for PDGM. But it begins with understanding what PDGM is. The fact that you guys are on this webinar is a good sign that you're taking in the education, you have a sense for what PDGM is, and that you can talk and share and plan with your team on how to prepare for PDGM. The second thing really is to analyze the impact of PDGM on your business. Again, great news. We're going to be introducing a lot of modeling tools in Axxess that allow you to look at your current operation as you're using our system, as you're running your operation, and look and project how PDGM will impact you if you continue business as usual. So again, this allows you to prepare for PDGM. And I'll get into a little bit more details as I get into the technology considerations for PDGM. Also, we really believe that you should implement really solid change management. It's important that you transition from the current PPS system to the PDGM system and have the right strategies in place to be able to make that transition. Also, the focus should be on your core competencies. You shouldn't be taking on anything strange at this time. You should be preparing to transition to PDGM, and taking on new lines of businesses may not be the right thing to do because it will distract from getting you ready for PDGM. Lastly, I think that you should look at more of the data to make decisions. So your people should be more data-driven in the decisions they make. You have to move from being anecdotal to looking at the data and having it help you drive the decisions you make. I'll give you an example. You can look at your patient mix and look at the percentage of patients you're getting that have a particular diagnosis code that may no longer pay on the PDGM. So again, making decisions to run your business so that you're not impacted by the regulations that are coming up on the PDGM. So being able to look at your patient mix is a decision that you can make that helps you be successful on the PDGM. So in summary, preparing your people, really, it's all about education on PDGM. And there's a lot of material that we've made available that you can avail yourself to. We have a PDGM resource center that has a lot of information out there. We have a PDGM booklet that summarizes PDGM very nicely for you. But it begins with preparing your people, educate them on the latest regulation, analyzing the impact of PDGM on your business, implementing change management to transition from the current system to the new PDGM system, focus on your core competencies, things you do very well, and also make data-driven decisions. For your process, it's time to fine-tune your processes. You need to eliminate waste, examine cost considerations, embrace automation as much as possible. If you're going to be doing twice as many wraps and finals as you did today, there has to be some automation there. And I'm excited to announce some of the changes that Axxess will make will allow you to automate a lot of your billing operation. You also need to streamline your operation and your administrative task. You have to get to the point where you're looking at your processes and establishing really, really good processes and doing the good processes better and eliminating the bad processes altogether. In terms of cost considerations, you should look at direct cost for episode management. You should look at adjustments to visit utilization. Should you be doing fewer therapy visits? Should you make any changes to your therapy utilization this year? There's so much to look at that drives cost in your business that you can look at. But we're committed to making sure our clients are successful, and we'll have a whole bunch of tools to help you be successful. So moving into the technology consideration, really your success begins with choosing the right partner. Axxess is the right partner for you. We have a user-friendly and powerful solution. It's cloud-based. It allows us to make changes to our system and respond to regulatory changes quickly. We have a mobile-first approach. We have mobile apps available to capture documentation at the point of care, verify your visits, and even have offline capabilities. We're an innovation leader. We have a fully integrated solution. I'm happy to announce that we've recently released a new hospice solution, and we're beta testing that. So now we have a complete suite of integrated solutions for our clients. We have a proven track record of meeting regulatory compliance, OASIS, COPs, any regulatory changes, we've met them very well. So the first step is really choosing the right technology partner that can adapt with you, that can be in the passenger seat with you to drive and navigate the landscape of home health with all the new regulations in home health. So how are we going to set our clients up for success? There are 4 different buckets that we want to talk about today. We're going to set you up for success by preparing for PDGM. We've done a lot of preparation. We've put on a lot of webinars. We've put out a lot of educational resources to make sure we're preparing, and we're preparing our clients and the industry for PDGM. We sponsored the NAC Roadshow. We're a national sponsor for that. And we've been very involved in making sure this entire industry is ready for PDGM. The next thing we're doing and offering is we're looking at impact analysis. We're going to help you analyze how PDGM will affect you, and we can model your past historical data in the PDGM tools that we have and project how well you do on the PDGM. We're also going to look at some of the workflow changes that we'll be making. So specific features and functionality that we will be considering, that we have already considered, and we're moving into our solutions in the next month or so, you'll start to see those changes be introduced. I'm glad to report that we will be completed. All the PDGM implementation will be done very early this year. So you have a lot of time to familiarize yourselves with the tools and get ready for PDGM confidently. The final thing is we will be supporting the release. We'll ensure our clients have all the material they need, all the educational resources, all the things that will make sure that they understand all the tools and all the components of PDGM and how we've made sure that they have all the tools available to them. So let's go into preparation. What ways have Axxess prepared for PDGM? Again, I've told you about all the webinars that we've put on. We've also participated since last year in a bunch of training and educational sessions ourselves. We've subscribed to a lot of CMS material. We participate in open door forums from CMS, their newsletters. We subscribe to the final rules. We ensure we're adequately and always prepared for all the changes that come down from CMS. Also, we've, with Home Health Gold being part of Axxess, we have a lot of tools that are available to you today already that prepare you for PDGM. And also, we've developed a roadmap based on the understanding of PDGM we have and the input that we got from a lot of our clients, suggestions that we got from our product managers and a lot of our clients that shared their ideas and thoughts with us. And we've incorporated that into our roadmap. And we've also had several design sessions. And like I said, we participated at the industry level on the different roadshows and all the educational seminars that have been out there. We've been involved in all of that. So the first real aspect of PDGM for us is preparing ourselves and preparing our clients for PDGM. and we've been very active in doing that. And of course, remaining attached to CMS to ensure that we're interpreting the rules correctly and translating that into features and functionality in our solutions. And also making sure our roadmap is completely aligned with PDGM so we can guide our clients to success on the PDGM. The next phase really is looking at impact analysis. It's important that we model PDGM in our solution. So from a technology point of view, we feel modeling and impact analysis should be a huge consideration for you. And so at the referral stage, we will be modeling. We have a PDGM modeling tool that breaks down the different case mix components of PDGM. So at the point of intake, you have a tool that can model how much you'll get reimbursed under the new model. Even today on the PPS, you can model and project PDGM reimbursement. So that's a tool that lets you see if I accept this patient and this is their diagnosis code and they're coming from their discharge from the hospital, and here's their functional level, it's low, medium, or high, and here's a comorbidity diagnosis code, secondary diagnosis codes. We can accurately tell you at that point what your PDGM projection will be in, as you intake those as you intake your client, as you intake your patients this year. We can model PDGM impact for next year, this year. We can break down if you completed so many visits, we'll tell you how much you get paid. The other thing we're going to do is when you start to assess the patient to see if you want to admit them, we will also introduce a new case mix analysis for you. So the PPS case mix is different, as I explained, from the PDGM case mix. So we can show you both and compare and contrast the PPS case mix to the PDGM case mix. Again, this allows your assessing clinician or allows your case manager or your director of nursing to understand how PDGM drives and affects your reimbursement. But from the case mix, you can already start to see what kinds of patients you should be targeting next year. We can also look at your historical data and show you what the revenue impact is going to be on the PDGM. So we can look at all your episodes that paid in 2017 and 2018 using actual data that we have in the system, run it through our PDGM tool and tell you that on the PDGM, you will be paid more or less, and here are the factors that contribute to your net gain or your net loss. And Axxess, again, will allow you to change and adjust your operation this year so that next year you are ready to go on the PDGM. So that's another tool that we'll be introducing in the next few months in our system. Also, we'll be alerting you in your clinical documentation any questionable encounters or non-specific diagnosis codes that will impact you on the PDGM. We'll be sharing coding errors with you and also showing you we'll be introducing tools that allow you to manage LUPAs very well so that you are able to understand what the LUPA thresholds are for each of your case mix groupings. Also, we will be warning as far as the intake, as far as referral, any PDGM alerts that we can share with you as early as the intake screen. We believe that sound revenue cycle management really begins not at billing, but it begins at intake. So we're going to be looking all the way from intake all the way to the billing and making sure we're sharing the impact of PDGM with you and modeling and projecting PDGM impact of your agency in our solutions. So at the referral level, at the OASIS level, at an agency level, and alerting you at different points in times as you run your operation, that here's the impact of PDGM to you. So moving on, what are specific workflow changes that we're going to make to ensure that our clients are successful on the PDGM? Like I said, we're looking at the referral and intake screen. We need to capture the community and institutional admission source. We also need to look at capturing the admission timing as well, early or late. And also, we believe that an integration with a referral management system, a few of them, will allow you to get your referrals into our system quickly. So we're looking to integrate a few referral management systems so that as you get the referrals, we're eliminating the need for you to type up that referral in our system. We will be automatically loading that from the referral management system into our system automatically. I mentioned intra-episode management. This is key under PDGM. We want you to have a good sense of how your active episodes are looking under PDGM. So we'll introduce an intra-episode manager that shows you a 30-day calendar, and it will break down everything you need to know from, the status of your RAPs to your looper utilization, your research decisions. It's going to share so much with you so you can manage the patient as the episode progresses, and you can make decisions that allow you to be successful. Also, from a clinical documentation standpoint, I mentioned that PDGM does not impact your clinical operation because there are no changes to the COPs, the clinical conditions of participation, or any of those rules. However, again, with the compressed time frame that the payment reform gives us, that PDGM gives us, of 30-day wraps and 30-day finals, it's imperative that you are able to have sound and accurate, timely and accurate documentation. So there'll be changes that we make there. We will also be introducing a wound manager. Wounds still pay the most under the clinical groupings. It accounts for more than, I think, 10% or 14% of all the reimbursement. So we believe that introducing a new wound manager that allows you to manage sophisticated wounds will allow you to be successful on the PDGM. We will also be introducing additional care mappings and clinical pathways so you can standardize the quality of care that you're providing. The sooner the clinical documentation and standard of care is met, the better for your reimbursement. And ultimately, it's always better for the patient outcome. That's very important for patient outcome as well. So these are some of the workflow changes that we're looking to introduce in the coming months. There are additional changes we feel we need to make on the billing side. Ultimately, PDGM is a payment reform. We feel that it's important that we're able to calculate the new PDGM payments for the 30-day units, that we're able to adjust some of our billing and claims management screens to share, to reflect the 2 billing periods under the PDGM guidelines. And also, we need to look at, from a reporting standpoint, how to recognize revenue under the new model. Instead of the 1/60 revenue recognition method, we will be introducing a 1/30 revenue recognition method. So some of our reports will be changing to reflect the new 30-day payment period on the PDGM. And like I said, PDGM is simply a payment reform, but it is imperative that you run a sound clinical operation so that you're able to be successful and make the transition to PDGM successfully. And finally, once we've implemented all those workflow changes and those modeling tools, all the prep materials that we've provided you, we will be supporting PDGM comprehensively. We will be asking for some of our clients to participate in our beta testing of PDGM in the coming months. Our plan is to release PDGM early so that, again, you get to take it for a spin and drive it and test it out in anticipation of the January 1st release. We believe that this is the right thing to do to ensure that you can adjust your operation and adjust your processes so that you can be successful in the PDGM. We'll be providing online help center, so there'll be a lot of materials available to you to learn about PDGM, and the specific changes in our products that we've put in place for PDGM. We'll be sending system messages to you, and also monitoring any support tickets that we get. The support ticketing center has been huge for us in understanding exactly what our clients need, what they request, and what their thoughts and issues are, and we're able to address them very quickly. Training manuals, of course, will make changes there and offer additional webinars that can, again, share strategies for you on how you can be successful. We know that our tools and our solutions will be there, and we'll have the tools and solutions in place, but we also want to make sure that you understand how to get the most out of those tools and functionality in our system. So going beyond PDGM. Going beyond PDGM is really, what's beyond PDGM? What should you be looking at? Business intelligence and data analytics is going to be huge going forward. I'm glad to report that Axxess has made a lot of investment in introducing a new BI analytics tool, which should be out in a few months as well. It will allow you to take complete control of the data that you capture in our system and run reports any way you like it. We'll be warehousing the data And you can expose that to any visual reporting tool like Tableau that you want. We'll have a lot of canned reports available in there for you, but you can go beyond that and look at different elements of your operation that you want to, and take some of our canned reports, make changes to them, and go beyond what we are offering. So that's something exciting to look forward to, being more data-driven and running your business based on the data that you're capturing. We also feel that integrations are going to be key. So e-referral integrations I mentioned earlier, we'll be able to capture referrals that come from the hospitals or other settings easily in our system. So e-referrals is high on our list. We'll also be introducing orders management integration, as well as a host of other integrations that are exciting, that will help you run a much more better business. And also, lastly, telehealth is important. We'll be integrating the ability for you to do telemonitoring, like remote patient monitoring, as well as being able to control visits in our solution. So that's really exciting. We're working to integrate some solutions there in the coming months, and you should look out for that. That announcement will be coming out very soon. But it's very exciting that we can go beyond PDGM, make you successful under PDGM, introduce BI analytics tools for you to get the most out of your data, offer you additional integrations to make sure you're connecting to other sources like orders management and referral sources, and also that you're able to take advantage of telemonitoring and telehealth, and being able to provide virtual visits that can save you a lot on cost, and also monitor your patient remotely so you don't have to provide as many in-person visits. So in summary, really, the journey to PDGM success is about looking at your people, it's about looking at your processes, and also making sure you have the right partners. Axxess is the right partner for you. This is a profound change. PDGM is a profound change in home health, but really there's nothing to be alarmed over. It's a challenge that can be met by using the right solutions. As I've showed you today, Axxess is looking to make the right changes in the solution, the right enhancements to ensure that your system can make the transition from PPS to PDGM successfully. Technology has a key role to play. However, you must see technology as a tool. Ultimately, you must look at the people and look at the processes and put the right tools in place to maximize your results. And I also want to just say that the successful agency under PDGM are those that prepare, those that are ready for PDGM, those that partner with the right solutions, and those that understand that really everything has to come together. The 3 Ps has to come together for you to be successful. And at this point, I'd like to take a couple of questions from the audience.
Okay, great. Andrew, thank you so much for setting us up for success with technology considerations for PDGM. It has been very informative and very exciting to see the advancements coming in the very near future. So time for just a couple of quick questions. Here's the first one. Our software vendor pulls diagnosis codes from our Oasis. Will that be okay under PDGM?
Absolutely. I think it's important to understand how diagnosis codes flow through the system. When agencies receive a referral, at some point in time, there's certain times they're admitting diagnosis codes that they receive. In our system, with the tools that were put in place for PDGM, we will be able to scrub that and alert you if that principal diagnosis is not groupable under PDGM. And we transition those admitting diagnosis codes into the Oasis assessment. At that point, the assessing clinician is able to make changes to them. And if you have a coding company can code and make changes as well based on the coding guidelines. And as it moves from your clinical documentation, it also moves to your claims. And remember, you have to submit your Oasis assessment. That has to be transmitted to the ASAP system. That is going to be compared with the diagnosis codes that you have in your final claims. So it's imperative that, of course, the PDGM says that the diagnosis codes are claim-based, but it's still important to understand that there's nothing wrong with moving and having a workflow that moves the diagnosis codes from the admitting diagnosis codes to what the assessing clinician does to the claims, as long as the the diagnosis codes in the OASIS are the same as the ones in the final claims, then there won't be any problem on the PDGM. But it's important to understand that there's nothing wrong with deriving the claims from the OASIS. What Medicare is going to ultimately pay is for the diagnosis codes that are in the final claims. But it's important that they're the same. So our system allows you to take those diagnosis codes in the OASIS and move them into the final claims.
Thank you. All right. One more question. Why is mobile technology important for PDGM? I thought laptops were allowed.
Mobile technology, as well as web technology, are both platforms that we support, and both of them are allowed, and there won't be any change going forward. The reason why mobile becomes even more important on the PDGM is because PDGM compresses the reimbursement time frame to 30 days. So it's important more than ever that you submit timely and accurate documentation. Mobile solutions allow you to capture clinical documentation at the point of care, and this cuts down on the time it takes to submit that, and also make sure that you're able to submit your claims in a timely manner. So the importance is on timely and accurate documentation, and mobile solutions give you that edge. Mobile solutions are important to capture the documentation early, but laptops are still allowed, and our solution, again, supports both mobile and web platforms equally.
Okay, looks like we have time for one more question. Let's see here. Will Axxess map out the threshold for a PDGM LUPA when you calculate the HIPS code?
Absolutely. Today, we can already do that today with our Home Health Go tools. Today, if you subscribe to Home Health Go, you can already see what your LUPA thresholds are. As you run through your episodes, as you scrub your episodes through the tools, we're able to project PDGM and see that based on your current answers in your OASIS, your reimbursement on the PDGM looks a certain way. But in addition to that, when we determine what your case mix, we can tell you the LUPA threshold associated with that case mix group. And going forward in Axxess, in our intra-episode management tool that I presented earlier, we will be sharing what the LUPA thresholds are. So as you approach that or go beyond that, you're able to track what your LUPA utilization is in all active episodes in our system. That will allow you to manage your LUPA, because LUPAs have become more important on the PDGM because of the different LUPA thresholds for the different case mix groups.
Okay, great. You know what? It looks like we have time for one more. If we start doing telehealth, is that going to be covered?
So telehealth will be covered by Medicare. And what Axxess is doing is we're going to be integrating a telehealth solution into our system by the end of this year. So as that is being covered and reimbursed by Medicare, we're able to partner with other vendors that provide telehealth and telemonitoring in our solution, so that you can take advantage of virtual visits, remote patient monitoring, and other secure messaging solutions that telehealth and telemonitoring options can provide for us.
Fantastic. All right. Well, that's all the time we have for questions today. However, we will follow up with those of you who asked questions we were unable to get to. Don't forget, we will provide you also with a link to the slides and posted video recording of this webinar. Thanks again, Andrew, for your expert knowledge.
Thank you. It was my pleasure.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.